والنيوبورن. والchallenges اللي احنا عندنا، لأن طبعا ventilation مش حاجة سهلة وعندنا different methods، بس أنا كنت أحب أشارك معاكم تجربتنا احنا مع nasal high frequency ventilation. But the newborn يعني has several challenges when it comes to breathing, actually. Immature breathing centers. The newborn is a nasal breather. Frequently, there is muscular fatigue, surfactant dysfunction, and we know that the newborn breathes with a high frequency and very small tidal volumes. And we're all faced with synchronization problem, whatever kind of ventilation strategy we're using. When we're faced with a neonate or an infant with ARDS, we know we're faced with a patient who has a high chest wall compliance and a low lung compliance, which is completely different from older patients. We're faced with problems related to ventilator-induced injury, which is why we're increasingly using non-invasive ventilation methods. And in Europe and the US, early use of CPAP, like we saw from the previous speaker, is recommended. But we have a multitude of methods to choose from. We can use methods using constant airway pressure, variable airway pressure, and we did talk about CPAP and end expiratory positive pressure. Oh, sorry. Oops. So what is non-invasive high-frequency ventilation? Actually, it's not a very complicated thing. We're applying a bias, so constant flow, that will generate a continuous descending positive pressure, and then we will superimpose oscillations at a constant frequency with an active expiratory phase. So it's very similar to bubble CPAP, really, or to CPAP. And we're probably ventilating the upper airways dead space. We don't really understand the full mechanisms, but we do know that it works. So this is from Jane Pillow, for example, showing that with bubble CPAP, we have a constant pressure and we'll have tiny little oscillations above this. And high frequency is mainly the same thing, right? We have a constant descending airway pressure with oscillations above it. And nasal high frequency ventilation combines the advantages and the characteristics of CPAP and HFOV, and it could be useful to avoid invasive ventilation and its complications. So we have a long experience of nasal CPAP, and we just had a brilliant talk about that. CPAP, using non-invasive interfaces, works by increasing functional residual capacity and oxygenation. And high-frequency ventilation is a gentle ventilation where we don't need synchronization. So that's an added bonus. It's true ventilation. It has an effect on CO2 removal. And we also have a wide experience, at least from invasive high-frequency ventilation. And combining these two together, we get nasal high-frequency. So how does it really work? That's an interesting question. We don't really know. We know it's complex. We know there are multiple mechanisms at work. We can have direct effects in the closer airways. We have moving through convection, and then we have convection and diffusion in areas with either open or closed alveoli. Will have different mechanisms, laminar flow, radial mixing, and we have diffusion. And then we come into the heart-lung interactions. So it's really quite complex. And I think there's a lot to learn still. What we do know is that in spite of the fact that we're mainly ventilating dead space, there is still substantial transmission of the oscillatory volumes into the lungs of preterm infants on nasal high frequency. And strangely enough, these tidal breaths are usually reaching the right and non-gravity dependent areas of the lung, as shown in this study. What does it really mean in clinical practice? We don't know yet. But we know that there are advantages. First of all, we can increase the main airway pressure without CO2 retention, since we have the oscillations. So we're very efficient in CO2 removal. We have less volume and barotrauma. And we can also improve oxygenation because we're increasing the functional residual capacity because we're recruiting the alveoli. We may be able to improve respiratory stability, for example, reduce the number of apneic spells, especially in infants with evolving BPD. And it could be a very useful tool if we want to avoid invasive ventilation and its complications. But there are still a number of questions. What is the effect on spontaneous breathing? And what about glottic constriction or dilatation? And we do know at very, very low frequencies, we may have suppression of the respiratory drive through some unknown mechanism. So the normal breathing pattern in preterm infants is complex. It's very variable. These are 5 different tracings from the same infant during one day. It's sometimes completely anarchic. And we are faced with the challenge of patient-ventilator synchrony. This is real life. This study is interesting. It was mainly on lambs, and it does show here in the CPAP, we're increasing the pressures, and when we come to non-invasive pressure support, the second line over here is actually the glottic muscles constricting. So the question is, when we think we are improving ventilation because we're increasing the pressure, for example, biphasic ventilation, maybe we're not actually helping the patient. Possibly there is a constriction of the glottic muscles, so the pressures are not really going into the lung. So we're not really actually gaining anything. But when we look at the H/V, even with increasing pressure, we do not have this phenomenon. So there seems to be at least animal evidence, probably it is the same in human infants, that nasal H/V does not influence glottic constriction, and that we actually have more glottic opening, and we're able to transmit the volumes into the lungs, as was shown in this study with the preterm infants. So the question could be, we're ventilating with a lot of air and a lot of pressures. Could there be concerns about, for example, gastroesophageal reflux? Actually not. Strangely enough, we seem to have a decreased number of liquid swallows as compared to controls. There is more gas-containing swallows, but there is no effect on a gastric tolerance. I'm going back now for the real thing, but the no need for synchronization is a huge deal. We know that even if we're using invasive or non-invasive ventilation methods, we have a real challenge when it comes to synchronization. At best, we have some pressure sensors or flow sensors to help us. They're difficult to calibrate, and we're often faced with patient-ventilator asynchrony. Nasal high frequency is real ventilation with real effects on gas exchange, and we're starting to have some clinical experience. We know it is feasible. So which patients could benefit from nasal high frequency ventilation? This is a survey from European NICUs a number of years ago. And you can see it's really heterogeneous when it comes to its use. Most of the units are using it for preterm infants, either below 1.5 kilograms or above, and some term infants. And some people use it regularly, most people occasionally. And basically, the main indications are nasal CPAP failure. Some units are using it immediately after extubation. And as you can see, there is a number of specific side effects that are observed, mainly abdominal distension, upper airway obstructions due to secretions, and we'll get back to that. But mainly it is rather safe and easy. The problem is we don't have many studies out there. They're mainly based on case reports. And these case reports say almost the same thing. When they're being used, for example, in the extubation, high-risk extubation failure group, we can see that by applying nasal high frequency, we can increase the rate of successful extubation in this patient population. We can also use it when the infants are using repeated apneic spells or CO2 retention. And using nasal high frequency will reduce the number of spells, will decrease oxygen requirements, and will improve CO2 levels, which means that we're able to avoid re-intubation in these patients. The number of episodes of spells, desaturations, and bradycardia can go significantly down when you apply a nasal HFOE as compared with CPAP. And this is significantly different. So what are the issues that we are lacking when it comes to, that we're facing when we're reviewing the studies related to nasal high frequency? First of all, that the problem is we really, in these studies, don't have much information on the baseline lung mechanics evaluation. We don't know about gas exchange, and we don't have gas exchange evaluation as an outcome for some of them. We don't know about alveolar recruitment. So basically, these studies are completely different. And it's difficult to have a solution, to have a conclusion related to that. But still, all practical experience says that nasal high frequency, when compared to CPAP, seems to be superior when it comes to re-intubation and CO2 removal. This meta-analysis, however, was not really able to conclude, except for CO2 removal seems very interesting, and the need for mechanical ventilation. When it comes to safety, when it comes to patient comfort, these are a number of things we need to assess. So I wanted to show you a video from one of the first patients we treated in the units. We're using a standard, this is an SLE ventilator, it's a standard ventilator, and we're using a non-invasive CPAP interface. As you can see, we didn't have a chin strap, so we've closed the mouth with some, as you can see. And the patient is really completely serene, does not seem uncomfortable. We can see that the oscillation is not transmitted. And in practice, we don't necessarily need to see the chest move because we're washing out the dead space. So we don't need to do as we do in invasive high frequency, increase the frequency or amplitude till we see the chest vibration. We can actually do that, see the effect without seeing this. And this is what we saw in the study we did in our unit, which we used to evaluate nasal high frequency as compared to nasal intermittent positive pressure ventilation when it comes to infants that were acidotic with respiratory failure who went to avoid reintubation. And as you can see, when it comes to, this is when it comes to the safety and comfort, gas stage and so forth, safety and comfort data showed that compared to nasal intermittent positive pressure ventilation, safety profile was the same. And we did talk about lung ultrasound, and we're a unit that does a lot of lung ultrasounds. The difference between the two groups shows that there was better lung aeration at 2 and 24 hours in the nasal high frequency group. And the difference was also when it came to comfort, heart rate, and so forth. Actually, the nasal high frequency groups had better comfort scores when it came to CPAP. So again, showing you just using any ventilator with a high frequency setting. Sorry about the sound. Don't cut that out. The frequency with mean airway pressure of 15, a frequency of 12, and we have an amplitude of 50. The baby is lying, it's undergone surgery, is comfortable, is being nursed with a chin strap. And the vibrations, as you can see, you don't see any vibration when it comes to the chest, but it's still very efficient in CO2 removal. This baby avoided reintubation, although it had an oxygenation score of 5 with FI2 requirements of 40%. And then what do we really know today? Since then, last year, we had this huge study that came up from China. This is the only randomized controlled study using non-invasive high-frequency ventilation as compared to nasal CPAP and nasal intermittent positive pressure ventilation. And the question is, what is the best non-invasive method to reduce post-extubation failure in preterm infants? So this is a huge trial. They had one group that went to CPAP, one group NIPPV, and one group nasal high frequency, and they had almost 500 infants in each study group. The population was comparable with a mean gestation age of 29 weeks. And these were infants where the primary outcome was the re-intubation, the duration of mechanical ventilation, and the number of ventilation-free days. And you can see from here, from this graph, that both nasal high frequency and NIPPV will reduce the number of re-intubations. And there is a tendency, or there is a result when it comes to nasal high frequency, that it reduces the total durations of mechanical ventilation in this group. There is no real difference when it comes to secondary outcomes like BPD, postnatal corticosteroids, or supplemental oxygen. However, when it comes to the safety profile, they're also comparable. So we don't have an increase when it comes to air leaks or in other types of, for example, nasal injury or grade 3 or 4 intracranial hemorrhage. So the key points are, in this randomized clinical trial, the use of non-invasive high-frequency ventilation slightly reduced the duration of nasal ventilation, and both nasal high-frequency and nasal intermittent positive pressure reduce the risk of reintubation when compared to CPAP. So this means that we do have a small advantage with the use of invasive respiratory support when it's being used as an extubation mode of ventilation. So which ventilator setting should we use? Well, it all would depend on which patients we're treating. Most people are using it to avoid re-intubation. But some people are using it as primary settings for RDS. We do know that by changing the amplitude, the inspiratory time, frequency, and pressure will be able to have an effect in gas exchange. However, we're also faced with the problem of leaks. So what we would suggest, or this paper suggests, is that when it is in post-extubation, we start around 10 centimeters of mean airway pressure, with an amplitude around 25 to 35 and a frequency around 10 to 12. However, if we're faced with the BPD population that are at high risk of re-intubation, we have much higher settings. This is non-invasive, so we shouldn't be afraid to go up. So the pressures will go up to 16 with an amplitude of 50 and a frequency as low as 8. Which interface? Of course, the efficiency will be reduced by the time of the type of interface. We can use the nasal masks, but we will need to compensate when it comes to the frequency and the amplitude as much as possible. And there is still a lot to be learned about patient comfort under these conditions. An important point is humidification. We know that the lower the frequency, the lower the temperature of the air and humidification, the total humidification of the air. So we really need to be concerned about humidifying correctly these patients. So when coming to use nasal high frequency, it is the same as invasive. We're going to be using amplitude as the main determinant of volume delivery and ventilation. Prong size might change the volume that's delivered, but we can increase the pressures to avoid this, easily achieving volumes in patients around 1.5 kilograms. Maybe leakage is useful. And of course, we need to be thinking about humidification. So we have an increasing experience. It's safe. It's technically feasible. We do not need to buy new equipment because we can use available machines in the unit and available non-invasive interfaces. Nasal high frequency reduces CO2, both in vitro and in human neonates. And today, the main target is for post-extubation and in infants with developing BPD. However, many questions still remain. So I'd like to thank you all and thank the teams at my hospitals at Paris-Saclay, and I'd love to invite you to visit us. Thank you.